Thanks very much for joining us here in Westmead, and I thank the Sydney West Translational Cancer Research Centre for hosting this event. My name's Tim Shaw. I'm one of the investigators on the Sydney West Translational Cancer Research Centre, and I'm also Professor of E-Health at the University of Sydney, and I chair, I guess, the Implementation Community Practice, which is the one that runs all the events that you see advertised and so on. So yes, thanks very much for coming. I'd like to thank Charlotte and Candice for organising this. They do a lot of work in the background to make this happen, and I encourage you, if you're not a member of the community practice, to join that, because we have a lot of events coming up. So today what we're talking about is MDTs and the MDT Symposium. We've actually got another MDT Symposium next week that the Cancer Institute's running. So Suzanne here is from the Cancer Institute. So if you're interested in attending that, that's got a slightly different angle. And I might even get Suzanne maybe after the break just to say what the key thrust of that one is, so you can see how relevant that might be to you. So I guess this is part of a series that we've been running, looking at multidisciplinary teams and what their role is within cancer services. Obviously, it's a key plank of how we deliver care within Australia. And I guess what we've been really looking at, particularly out at Western Sydney, and a lot of this work's being led by Lindley Evans, who's talking today, and Lindley's been doing some great work about how we kind of classify or rate where our MDTs kind of sit in a kind of maturity model. Really what we're looking at is we bring all these clinicians together every week or every 2 weeks, and we obviously look at direct patient care for those patients that are being reviewed, but that's a huge opportunity. We bring those people together to look at how those teams can actually really drive implementation research and drive other things within the service to actually lead that kind of improvement. And I think it's great today that we've actually got some clinicians coming to share their experiences. We've also got people like Anna DeFazio in the audience, and I haven't got Anna to come up today, so she's been talking for us quite a lot, so I didn't actually make you do a presentation today, but Anna's doing a lot of work about how we embed like the basic sciences into multidisciplinary teams. We gave a great talk about 2 weeks ago as part of this series out at North Shore on the work that Anna's doing in the gynecological MDTs. So that's the kind of thrust of it. I mean, for me, I think we're almost being killed by our own success in implementation science. Like when we started out about 7 or 8 years ago, there were hardly any projects. It was really easy. There's tons of projects kind of rolling into this space now. You'd have heard of the Prompt, all these other different kind of projects, pain management, stop cancer pain, and you know that in some respects that's kind of almost overloading the system. And I think we need to work through that and work out how MDTs can help coordinate some of that activity. And then I think the key step is how we get these implementation projects from a kind of an academic focus to an implemented routine kind of implementation process. And I think MDTs are going to be pivotal around that. I think the other thing to really point out with MDTs, and I think Nicole will talk to this, and Lindy's very aware of this, is the massive range still we've got in MDTs, from ones which are really just starting out through to ones that have been running for years and years in a really mature model with lots of functionality and features. And we kind of acknowledge that now. We expect there's people in the audience that perhaps come or represent both of those different kind of spectrums of teams as well. And that's always makes it kind of difficult to how you pitch a presentation like today. So, and we've kind of graded it from starting out with some kind of the basics of MDTs, I guess, moving through to more sophisticated models. And it's great that we've got Barbara Page from Queensland coming down to talk to us about some of the fabulous work they're doing in the lung cancer space up in Queensland. So that's really exciting. I think that's probably it from me to introduce today. So, and then we are also finishing with a panel with two practicing clinicians from multidisciplinary teams, and also Nicole Rankin, who many of you will know, and Nicole's a presenter as well. So Nicole's one of those kind of researchers that's obviously embedded or working closely with MDTs. So we kind of get that balance on our panel. Have I covered everything you want me to cover, Candice?
Yes.
Good. Okay. So look, we invited Fran. Who knows Fran Boyle? I imagine that a number of you know Fran Boyle. So we invited Fran to come, but unfortunately she knew she wasn't here when we invited her first up, and she said we should do a video production. And I think Fran's a little bit of a frustrated entertainer somewhere in there. So Fran's not a communication stuff. So Fran and her, I think it's her daughter, prepared a kind of a 5-minute kind of somewhat humorous, I think, view of some of the basics around MDTs, getting it right. So we're just going to show that first up, and then if we want, we can have a brief discussion of some of that. So Fran really wanted to be part of it, so she got her daughter to sign up. It's funny actually, because I just came from a launch at the University of Sydney with Alan Joyce and Neil Perry, actually, who are forming a partnership with Charles Perkins Centre at the University of Sydney with Qantas, looking at how we make the long-haul flights more comfortable and get people healthier in that, particularly the new Dreamliner that's flying from Perth to London non-stop. And you'll notice the clothing that Fran is wearing. It does signify the class she flies in, but it links Qantas with this programme of work.
Like me, you're probably a frequent flyer, and you always hope to make it to your destination safely and return home again. There are 3 key moments that we rely on our flight crew to ensure our safety. The first is when the cockpit crew introduce themselves and go through their pre-flight checklists. We don't see this happening, but over the past few decades, the use of these streamlined lists have ensured that important things don't get left out of preparation, and they've improved airline safety immensely.
Welcome aboard.
The second is when the cabin crew interrupt us to give us the safety briefing. All devices get switched into flight mode, and we pay attention to all possible escape strategies, at least in theory.
It's important to pay attention, even if you've heard this before.
The third moment we hope never to see, and that's the way they would work as a team in the event of an adverse event, to find a way to get us out safely, and afterwards to investigate to determine what went wrong and what needs to be fixed in their safety systems. In recent years, the Safe Surgery Program of the World Health Organization has promoted the use of airline strategies to improve patient safety during operations. Operating teams stop what they're doing, down tools, take a time out, and run through a checklist. Everyone is introduced, and anyone can and indeed should speak up about any concerns they have for the planned operation. Adverse outcomes have been reduced with these careful communication strategies. For patients with cancer, step 2 is the MDT meeting. It's a chance for a safety briefing to occur, ensuring that treatment is ready for takeoff and that all possible factors affecting the journey have been considered. With a team of highly trained, dedicated professionals, what could possibly go wrong? Insufficient notice may have been given to team members who need time to prepare, especially those theoretical radiology, pathology and medical oncology types who might need to assemble the latest evidence to address a particular patient issue. The setup of the meeting room may inhibit contributions from all participants. Some may not be able to hear, some may not be able to make eye contact, and some may not have been introduced. Someone may be sitting at the back nursing a concern, and if the chair doesn't ask them directly, they won't be likely to speak up and will all miss out on knowing what their issue was. You may, like me, be a bit desensitised to the safety briefing, having heard it all before. Jet lag sets in, and for those of us of advanced age, concentration wavers. You may be sending last-minute texts or emails, having failed somehow to switch into flight mode, and are distracted by events outside. You may worry that your perspective on the patient is too sensitive to share in the meeting and don't trust that it will be handled confidentially. Perhaps you'll take it offline, or perhaps not mention it at all. The way the meeting is chaired makes a great difference to whether all perspectives are aired and recorded without losing momentum and wasting time. Also critical to effectiveness of the MDT meeting is the checklist you have prepared to structure and record your decisions. Your checklist is likely to change over time as you respond to advances in diagnostic and therapeutic options for patients or available clinical trials. Like any team that works in a risky environment, it helps to ensure there is a feedback loop between new evidence and your team decisions. After key international meetings or guideline publications, changes to team processes need to be shared. This may occur at a dedicated time within the meeting, but may need a separate meeting outside normal patient care. The other time information needs to be shared is when something goes wrong. Either a near miss, an adverse event, or a complaint ought to bring the team together to ensure patient safety and review team processes. Too often we hear that the patient and the clinician are isolated in this situation, which helps no one. Training together to manage communication in adverse event scenarios helps to ensure safety of patients and clinicians. So as you consider how to take your team to the next level, the following checklist may be useful in providing some things to consider. Bon voyage!
Okay, so anyway, so that was Fran's moment of fame. But I mean, look, I think obviously, did anybody have any comments they want to make about that? Any ideas they saw or reflections on that? I mean, I think the bit that interests me most is probably obviously. I mean, it's amazing how many times you go to teams you see them so dysfunctional. Anyway, we sat. Well, this is another royal we. My team sat through about 40 or 50 team meetings in a big cancer centre not far from here over the last couple of years, and it's remarkable the difference and how many teams don't kind of necessarily get that all together and get it right. We think we do, and it seems so basic, but some of the fundamentals are not got together. I think the other thing we really felt was some of the key things was the documentation. Is Nirmala here? So Nirmala and I had an MD student, Nirmala, or a couple of MD students looking at kind of documentation around the breast team and how rigorous that is or not, and what a challenge it is to actually get that accurately recorded so you can store that data. I know that Linda, you're working on that whole process of, it's still really difficult for teams to get basic data stored and accessed. And Emily Stone, who is my PhD student, who's actually chair of the St Vincent's lung cancer team, is also looking at that process. And I still don't quite understand why it's quite so hard in what we do. I think the other thing that came from that, and this came out of the study we did last year, is I think the teams that function really well in getting new data into the teams actually have to do extraordinary meetings. I'd be interested in what Barbara might reflect on that later, but I think the actual team meeting is so busy that to get other activity and other things put into it, or I don't know whether you'd agree, Anna,
I
or not.
totally agree. In fact, I was just saying we had our ASCO report yesterday. So the MDT meeting in the morning, but then lunchtime meeting to deliver the new findings from ASCO. I think definitely has to be a different meeting because it's a different mentality.
Yeah.
The MDT meetings are sort of very, have to be very quick, very focused. Whereas to deliver that new information, you need a time for discussion
And do you find that the team happy to go to that?
Oh, absolutely. In fact, very, very keen to go to it.
Yeah.
So whenever there's a major conference, there's the meeting set aside later in the same day to discuss those findings because they have impact on they may have impact on regular treatment,
Yeah.
on changes that there may be to standard treatment.
And I see that as a well-functioning team that has the maturity to actually kind of establish that. And I don't think that's universal though. Would that be universal, Lindy, from what you've looked at? Or?
No, but we are, some of the work that I'm doing, we are saying quite clearly that we think they should do it in an extraordinary meeting, not try and do it in a meeting. And certainly the more proactive teams have agreed to that and organised the time.
We have had, if it's only 10 minutes, you can fit it in, but usually the meeting's too busy to really devote the time to discuss the implications. So.
I tend to take 10 minutes to suggest they need a longer one.
Yeah, look, and I hope that's something that we can discuss in the panel of some of the kind of mechanisms that go into actually making that kind of the MDT being more than just the meeting on a regular basis.